Good morning, everybody. So, in my practice, we do a lot of foot care for pediatric patients, which is basically, young people, right? So we see all kinds of issues, and today I'm going to show you an X-ray on one patient, so as you can see what we deal with. So this ability for us to actually do things on the new X-ray, digital X-ray age, it's amazing. So we can actually look up on the computers and take a look at the X-rays. We used to do them on a screen with a fluorescent light behind that. Now I'm giving my age out. Anyway, so when you look at the foot on a baby, this is a 3-year-old. So you can see different bones here, but you see a lot of tissue that's not really bony yet. It doesn't have any bones. So let me invert this a little bit so I can show you. So as you look closer here, this here is the ankle bone right there. This here is the heel bone. This here is the tibia, fibula, which is the leg bones. Now over here, you can see the cuboid bone, and these are smaller bones called cuneiforms. So there's the inside, the middle, and the outside bones of the cuneiforms, which carry the first, second, and third rays, which is the first, second, and third metatarsals, and then the toes. And interesting part about this is that the growth plates are right here. I don't know if you can see them, but there's a growth plate right there. On the smaller toes, the growth plates are at the ends. They're not on the bottoms. And again, growth plate, growth plate, growth plate, and so on and so forth. But over here, there should be a bone right there. And that bone is not yet solidified. There's a small something happening. Because it's cartilaginous, you're not going to see it on X-ray. So you're not going to see much happening. But soft tissue-wise, you can see there's a little bit of bulge right there. And that's because the talus, which is the ankle bone, is twisted over. So if this is twisting over this way, there is what we call kite ankle, and it's really wide on this patient, whereby the angle between the calcaneus, which is the heel bone, and the talus, which is the ankle bone, is a little bit wider than normal. Because this is going inwards, you can see his forefoot is kind of turning in as well to try and accommodate that force. Now, he's not standing with this picture, so you really cannot see the biomechanics of it as much, but you see a little bit of change, which is this little bulging that's happening. So the talus goes in this way, the midfoot is going this way, the forefoot is going this way, and then look at the toes. The small little toe is going in too much, fourth is a little more, third and second not much, and then the big toe going in this way. So you end up with deformities in the forefoot secondary to what the talus, which is the ankle bone, is doing at an early age. Now, is this normal for early age to have this? Not really. It's not a good idea to have the talus dropping down like that. It needs to be fixed or helped, let me put it this way. What I mean by that is you need therapy, you need things of that nature, good shoes, good arches, stuff like that. But you need to see this for you to assess. So now we see it. Now we also do x-rays later and see how the patient's progressing with the treatment that we started. But I just wanted you to see this. So this is the one foot. I'll show you the other foot. So now we're looking at the other foot, and this is the other foot. And again, we're going to invert this because you don't see much. There you go. There's your talus, there's your calcaneus, cuboid, cuneiforms, and again, you can see a shadow of the navicular bone, which is the bone in between those two entities here. You can see also the toes are moving in, the little toe going in, and so on and so forth. Same problem, left and right. Again, patient is not standing, so you cannot really assess the biomechanics, but you can see certain things like the bulging here, the zigzagging going on, which is wrong, things to that nature, kite angles too big, and so on and so forth. Again, but this is not a pure thing because you don't have the patient standing. You need standing pictures for you to assess that for sure. I'll show you the laterals. This is actually a lateral oblique view, so you're looking at it from an inside portion, outside the mean to the inside downwards on the 45 or so. And we do these pictures to see if there's any fusions. Well, kind of too young to have any, but sometimes there is. So we just try to see that, you know, some hereditary diseases or genetic deformities. You can see stuff. And thank God this patient doesn't have any of the stuff here that we see that is very prominent. So again, we always invert to see if we can see anything different, and then it shines up. This is the fibula, and you can see the lateral malleolus growth, and this is the growth plate right here. There's not a fracture. This here also is the growth plate of the tibia, and it's growing nice. And again, you can see all the growth plates everywhere. You want to look at that to make sure. Now the calcaneus have a growth plate here, but again, too young to see the calcaneal growth plate in this area. It will grow up later. It'll show up later. Anyway, so let me show you the other pictures. This is the other foot, and again, I'm gonna do a inversion just to see what's happening. You can definitely see calcaneus, talus, cuboid, cuneiforms, metatarsals, leg bones, lateral malleolus, medial malleolar, growth plates. All of them are there. We look and make sure everything is in proper positioning, everything is looking good. A little bit of lucency here, we'll just keep an eye on that. It could be like a bone cyst or something in the future. We'll see what that happens. Again, this is a lateral view, but it wasn't a weight-bearing view, and so the patient really, you cannot assess the biomechanics of it, but you can definitely see the problems that we are getting if the talus is coming down too much. We really need to assess this in a weight-bearing situation. Patient is not really, most likely was not cooperating with the technician. So, you know, if they can, that's good. If they can't, that's okay too. We just want to have a baseline for right now, just to make sure all the plates are there, everything else is there, and all the bones are growing properly. And this is where bone growth comes into play, and knowing the bone growth. So the navicular does not come in until like 5 or 6 of age, and you want to see that later on. And this is the other foot, and again we're looking at the different growth plates and make sure that everything is in place, everything in proper positioning, and again that lucency a little bit. Not unusual to see something like this, but right now I wouldn't make a big deal out of it, but you really just watch it and make sure everything's okay in the future. So here you have it. Now you know a little bit more about pediatric foot anatomy, and if you have any questions, by all means reach out, let me know. Okay, thank you so much, and if you like it, just like and share. Thank you so much, everybody.